I'm happy to introduce the last speaker of this session, which is Evalotte Mörelius. Evalotte is professor of, I think, pediatric nursing. Is that your title? Yeah. At Linköping University, after first being professor in Perth in Australia, where she still is Honorary Nursing Research Consultant. And Evalotte has measured stress responses in Linköping for many years on all children living there, almost. Yeah.
Yeah, probably.
Probably, yes. Okay.
Not yet.
Well,
still much
welcome.
to do. Thank you so much, and thank you to the organizers for inviting me to speak here today. It's been a fantastic day, I must say. Really, really good sessions, and I'm so proud to be one of the speakers here. I will talk about developmental aspects on stress and enablers for well-being. Maybe a bit ambitious title. We'll see how it goes. It's been a long day, so if you fall asleep, I will notice. I will start by repeating what stress is. I don't think we can do that enough times, so that's what I will start with today. The concept of stress, it's really three different parts. We have the stressor, we have a stress reaction, and a stress response. And a stressor is something that disturbs the allostasis, right? So for newborns that can be, for example, not being able to breathe, hunger, pain, as we heard a lot about today, and being abandoned, neglected, abused, etc. The body reacts to the stressor in different ways. And that's why we have the stress reactions. And fight or flight, probably one that you've all at least heard about or maybe even experienced many times. And as Pete showed us in the presentation earlier this morning, it seems like it was a long time ago, the boy who struggled in the acute ward, he really had a fight or flight response. Tend and befriend is another reaction where we tend to look for our loved ones to make sure they are safe, and we seek social support in times of challenges. And we have the play dead reaction, where the blood pressure drops, the oxygen drops, the heart rate drops. It's very common in animals, but also in preterm babies when they have an overload, when it's just too much, so they need to shut off and say this is enough. A normal stress response is characterized by increased heart rate, increased blood pressure, and fast, shallow breathing. There is an energy mobilization where there is a rapid energy release of glucose and fatty acids from the liver. And this is like a cocktail circling around in the blood to give energy to the parts that are most in need of energy during a fight or flight response, which is the heart, the brains, the muscles. And there is a redirection of the blood, or there is an affected blood coagulation. So in case if you are getting hurt, have a wound or something, you should not bleed to death. And then we have the release of hormones. Adrenaline, noradrenaline, and we have the cortisol. And they represent different systems. So I have focused on saliva cortisol to reflect the stress system in preterm infants. And the benefit with cortisol is that it's a really stable molecule. So it's pretty easy to collect and analyze and capture because it has a pretty long half-life time if you compare to adrenaline, which is really, really quick. So cortisol is regulated through the HPA axis, which is activated through the amygdala and includes a negative feedback. So this feedback loop goes back to the hypothalamus and the pituitary, saying, okay, we have enough cortisol in the bloodstream now to handle this stressor. So you can turn off the production or the release. Cortisol is secreted in a circadian rhythm. So we have the highest levels in the morning, around wake up, and the lowest level around bedtime, where other hormones take over, like the sleep hormones and growth hormones in children. However, when there is an ongoing stress, so there is one stressor taking over after the other one, and the body doesn't get the time to rest or recover, then there is a risk for long-term stress. And we can see that by changing the circadian rhythm, by having a lower level of cortisol in the morning and a higher level of cortisol in the evening. So the curve is flatter, and there is a less slope, there's a less difference between the morning and evening levels of cortisol. Infants in neonatal intensive care have significantly higher cortisol levels as compared to healthy full-term infants. And extremely preterm infants have higher cortisol across the first years when we compare to full-term infants. There is also a positive correlation between the number of painful procedures in the NICU and the cortisol levels. So while acute stress is necessary for survival, there is a problem with high cortisol levels. And that is that it hinders communication between neurons. So they don't connect, they don't wire together, and they don't communicate. And that is because cortisol, do I have a pointer here? Yes. Cortisol are blocking the receptors, so the communication is not happening. And cortisol affects the whole body, all organ systems, and especially the hippocampus, the area around hippocampus in the brains, and the prefrontal cortex. This means that high levels of cortisol are toxic for the brain on both short and long terms. It decreases learning, memory, concentration, planning, decision making, and also impact the behavior, more anxiety, aggression behavior maybe, or irrational behavior. So as an example of long-term consequences of preterm birth, this is a recent systematic review of 58 Norwegian studies of very low birth weight infants born in the late 80s. Their findings show that there was an increased prevalence of brain structure pathology, lower cognitive performance, mental health problems, visual and physical health impairments, and so on. So we can say that premature births, if you have a premature infant, they are most commonly exposed to different stressors, and that can be intensive care, it can be pain, and even separation from the parents. We also know that they have increased risk for cognitive, health, and behavioral problems. And the mediating factor is developmental changes in the stress system, because the stress system develops during this time and is vulnerable for what is happening to the child. So what we need to do is we have to break this circle or process, intervening somehow to make sure that this does not happen to the infants' brains. So we can measure cortisol and we can learn about how the stress system develops. But we also have to know when we use cortisol in different research studies that we need to consider some aspects. And one of them is gestational age, because infants are born without the circadian rhythm. As you can see in this slide here, each colored line represents one child across 24 hours, and they are very, very different. And this is just a small example. So we have seen that full-term infants develop a circadian rhythm of cortisol at 1 month's age, approximately, and that persists throughout the first year if they are healthy. We can also see that preterm infants develop this cortisol circadian rhythm at 1 month's corrected age, which persists throughout the first year if they stay healthy. So from this we can conclude that it's more important for the maturation is gestational age, not postnatal age. And as seen in the blue dots here, it's not here, extremely preterm infants have a flattened diurnal slope across the first year compared to very preterm and full-term infants. And in this slide, the greens are term infants and the orange squares are very preterm infants. And as you can see across the year, the first year, the blue dots they don't peak. So that means that their stress system is altered. And in these violet dots, we can see that extremely preterm infants also have a blunted response to vaccination at 4 months compared to very preterm or full-term infants. And the last ones here, these violins, are the extremely preterm infants, and you can see the blunted response. Oh, sorry, the small ones. The first ones are the extremely preterm infants. Another aspect to mention then is infant sex. There are differences in the HPA axis present in infants before puberty, and we can see higher levels in boys compared to girls. And this seems to also be important and true for infants. So also here we can see that boys seems to be more vulnerable even when it comes to the stress system. So that is something to consider in research. Another aspect is habituation. We don't talk about that so often, but first time the infant experiences something, they react with a cortisol increase. However, when they have experienced this a couple of times, like a diaper change, for instance, they don't react with a cortisol peak anymore. If anything is normal, everything is normal, they should not react. Painful procedures, however, without pain relief, that is, continue to increase saliva cortisol levels forever. Which it should, because that is something that is dangerous for the body. It's a threat, and you should react. So you should have a cortisol response when you are exposed to painful procedures. Illness, poor health, premature birth can delay habituation to a non-painful stimuli or cause dishabituation. So that means that preterm infants, when they are exposed to repetitive stimuli, that leads to sustained stress responses. Then we have psychosocial aspects in the family. Infants have less difference, that is, a flatter slope between morning and evening levels in mothers if mothers have social problems. And likewise if mothers are smokers. And infants in psychosocial high-risk families have a higher saliva cortisol variability across the first year. And that means that they go in and out from the circadian rhythm. It doesn't stay when it has developed, but it goes in and out. And then we have parents' mental health, which also affects the infants. And often when we test these, we look at something we call biological co-regulation or neurobiological co-regulation, and that is the synchrony between the parents and the infant's biological states. We measure if they are synchronized. So we can see that biological co-regulation can buffer the child's stress and protect the child from overexposure of cortisol. The biological co-regulation is particularly prominent during times of increased stressors. And that is the times when the parents can help the infant to self-regulate or buffer the child's stress. So we know that mothers who have less sensitivity towards their infant signals, the child's behavior, also have weaker saliva cortisol co-regulation with their infants. So it goes hand in hand. Unfortunately, parents can be present in the NICU, but emotionally unavailable. And parents of preterm infants have high risks of stress and anxiety, as you know, but also post-traumatic stress symptoms and post-traumatic stress syndromes, postpartum depression, and unsuccessful bonding. So, what can we do? Well, some examples are to protect the well-being of the infant and to protect the development of the stress system and build stress resilience in the children. Appropriate pain relief is one example. Human touch, oxygen, nourishment, love. I have to add that now, doesn't I? Emotionally available parents who can read, interpret, and respond appropriately to the infant's communicative cues. And a strong biological co-regulation. And that only develops if the parent and the infant stay together. And some examples of that is that sharing the same NICU environment day and night facilitates the biological cortisol co-regulation in the mother and infant dyad compared to when the parents sleep at home. Then that process is delayed. And the same continuous skin-to-skin contact facilitates the biological cortisol co-regulation in the mother-infant dyad compared to intermittent skin-to-skin contact. And twins sharing the same environment also facilitates the biological co-regulation between the twins that can be beneficial for them. So, but we have much more work to do here, and some gaps we have in the research here is regarding enablers for development of the infant stress system. Is some example of interventions that we know have positive effects for the infant and the parents and the families. However, they are not yet tested for co-regulation or maybe not enough evaluated. And some examples are or include, but are not limited to, music therapy, maternal voice, prone position, single rooms, and interventions to decrease stress for parents. So we still have a lot to do. However, there are several interventions on the market that improve infants' well-being, and also with potential to improve parent-infant interaction and create a co-regulation. I'll show you some slides from a pretty recent meta-review of 11 systematic reviews, including a total of 34 interventions. And this was written by Professoriate et al. 2018. And these 5 interventions were the most commonly reported, and also kangaroo care and the mother-infant transaction program were the most beneficial across different outcomes for the preterm infants. They also gave examples of that some interventions are facility-based and some interventions are more home-based interventions. But also examples of interventions with home and facility-based components. And they could show in this systematic review that that could be a very good combination for having good outcomes for the preterm infants and the family. I come from Linköping, and in the NICU in Linköping, they are NIDCAP certified, and they do a lot of NIDCAP observations, but felt sometimes that they didn't have time for the children that were moderate to late preterm. So they wanted to have something to give these parents during a short hospital stay. So they wanted to do something to help the parent-infant interaction before they let the parents go home with the child. And in a Swedish context, these families were pretty much taking care of themselves in family rooms, and parents were staying there 24/7, and also siblings sometimes. So they didn't get so much attention as the very preterm or the extremely preterm infants. So we took a look at different interventions that had the potential to be included for moderate to late preterm infants. And we found some, and a few of them were appropriate for infants that were late and moderate to late preterm. Like, for instance, kangaroo care and the MITP program. The MITP program includes 11 sessions, and even the modified version includes 9 sessions. So it was a bit too long for satisfying the staff in the NICU. So they built another intervention, including 3 different sessions, starting within after 72 hours after birth, and 2 sessions were provided in the hospital and 1 at home. And tested this. We did a test. We did a randomized control trial to test if could this really be enough? 3 short sessions where you go into the parents, you guide them a little bit, talk about what they are doing and how they will proceed during the day, and so on. We included in this randomized control trial 143 families in 2 arms, and they were allocated to intervention, standard care, or interaction support, and the control group with standard care in the NICU. We evaluated this at 1, 4, and 12 months with different stressors. We used the bath, we used the still phase, and we used Bailey scales as stressors. And the follow-ups, when we use sensitivity scales to look at interaction and emotional availability, we looked for co-regulation and also for cognitive development with Bailey's case. We have preliminary results that I have not included here, but I can say that mother's availability, acceptance, and non-hostility were significantly higher in the intervention group at 1 month. At 4 months, there was a strong co-regulation in cortisol between the mother and the preterm baby. That was significant. That was in the intervention group, but not in the control group. And at 12 months corrected age, the infant scored higher on receptive language. So there is potential with only 3 sessions to improve parent-infant interaction and long-term well-being. So to summarize this, I would like to say that excessive or prolonged exposure to high cortisol levels during the neonatal period can have adverse effects on development of the stress system, though affecting health and well-being across the lifespan. And the effects on the stress systems are both in the HPA axis and in the circadian rhythm, and in the reactivities to different stressors. Extremely preterm infants are the most vulnerable for adverse development of the stress system, so we really need to take care of them. But we should not forget about the moderate to late preterm infants. They also need attention. Parents' emotional availability can buffer infant stress, and parents need support to be able to support their infants. They don't do that by themselves in an environment that is not at home, not their own, can even be a bit frightening. So my take-home message to you is to mitigate infant stress. Each NICU could or should incorporate an evidence-based intervention to increase parent-infant interaction. The intervention must be suitable for the country, context, gestational age, and the family for which it is delivered to. And I would like to say there is a smorgasbord of good interventions, but probably not one intervention that fits all. Thank you for your attention today, and I'm so happy that some of you are still awake.
Thank you very much, Evalotte, for this very nice presentation. I wonder if there are any questions or comments for Evalotte. Maybe I can ask meanwhile. I don't see any. Did you ever follow up these responses in the babies when the children grew older? Do they have the same response pattern then?
It's a very good question, and something that I have on my agenda to-do list.
Okay. Well,
we followed infants, full-term infants, and for 1 year. We followed preterm infants for 1 year, and infants in families of psychosocial problems for 1 year. And we looked at the circadian rhythm, basically. That was what we could manage to do because we followed them for every single month. So we haven't looked at the reactivity and how that is later on. But as I showed you with the vaccinations, that study we did together with Edinburgh University, and they used some of our materials, and we collected that with the materials collected there. And we could see that there is this blunted response to vaccinations. And that has been shown in other studies as well. So there is something happening. Yeah. Okay. Definitely.
Are there, you want to, yeah?
Thank you, Evalotte. Very nice presentation. Since we are so many NIDCAP people here, I just want to comment that, isn't it true that this intervention that you have, it's actually NIDCAP professionals doing the intervention?
Thank you. Absolutely. When we did the randomized control trial, we had to have facilitators that really knew what they should do. So, and also to describe, to have a study published, you need to have, you know, the facilitators are really important, and especially when you do something that is emotional, cognitive, and you do some kind of behavior procedure, you need to know that all the persons do pretty much the same thing when they go into the room and talk to the parents in the family setting. So in this study, we used NIDCAP providers to do the study. Yes, that's correct.
No more comments, then I think we should move on to the next session and thank the speakers of this session.
Thank you.
And